Assalamu alaikum. This is Assistant Prof. Dr. Al-Dolaymi, Consultant Orthopedic Surgeon. Our subjects today, we will talk about bone tumor. In this subject will be divided in 3 parts. The first part, we will talk about the principles of bone tumor. Second part, we'll talk about the benign bone tumor, and in the third part we will talk about the malignant bone tumor. As a definition of a tumor, it is a disturbance of normal cycle of bone. Either there is overgrowth or undergrowth. Bone tumors, so it's divided into primary bone tumor and secondary bone tumors. Primary bone tumors could be, as we know, bone tumor could be, as any true tumor, could be benign tumor or malignant tumor. What's the special for the bone tumor is a benign tumor are more common than the malignant tumor. So the tumors of the bone mostly are commonly a benign tumor. This is the primary tumor. The secondary tumor, it is a metastatic tumor in which the malignant cells are found in other organ and reach the bone through the blood stream or due to even direct metastasis. So in general, we have 2 types: primary bone tumor, which is the tumor that occurs in the bone itself and could be benign and malignant. The other is secondary bone tumor due to a tumor in other site. So the primary neoplasm of the skeleton are in general are rare, and it is account only about 2.2% of all over the human tumor. Children are more affected than the adults. The most common tumor is a matrix producing and fibrous producing tumors. So the tumor in the bone is rare. It is about 0.2% of all over tumor, and most commonly frequently affect the children. Type of these tumor, either matrix producing tumor or fibrous forming tumors. Among the benign tumors, the osteochondroma or exostosis and fibrocortical defect known as fibroma are the most frequent. Excluding malignant neoplasm of the bone marrow origin, like myeloma or lymphoma, the osteosarcoma is the most common primary cancer of the bone, followed by chondrosarcoma and Ewing sarcoma. The classification of bone tumor is occur according or can be classified according to normal cell or tissue of origin. Yani we classify the tumor bone tumor according to there is the cell origin of the tumor in the bone, and also can be classified according to apparent pattern of differentiation. So the lesions that do not have normal tissue counterparts are grouped according to their distinct clinical and pathological features, either a bone forming tumor or cartilage forming tumor, fibrous tumor, hematopoietic tumor and miscellaneous tumor. فالhematopoietic tumor is account, as I said, it is most common and account for 40%, and they are all malignant, like myeloma and lymphoma. Chondrogenic tumor, which is in which the cells are chondrocytes, it is osteochondroma, enchondroma, chondroma, chondroblastoma, chondromyxoid fibroma. The malignant tumor is chondrosarcoma, undifferentiated and mesenchymal chondrosarcoma. The other type, due to his, according to histological type, it is 19%, which is osteogenic. Yeah, this is mean that's the bone, like osteoma or osteoblastoma. So there is a tumor, the bone itself is abnormal growth, and the malignant type is osteosarcoma. الأنون هي giant cell tumor and young cell tumor and giant cell tumor adenoadenoma, and these are even nowadays they consider it as a systemic diseases, even not a bone disease. Histiostatic, fibrous histiocytoma and malignant fibrohistiocytoma, fibrogenic fibroma and fibrosarcoma. Notochord here, chordoma, which is the tumor of the sacrum and notochord, and vascular tumor hemangioma, hemangioepithelioma, واللايبوجينيك اللي هي اللايبوما, اللايبوساركوما, ونيوروجينيك النيوروليموما أو الشوانوما. So these are the classification of bone tumor according to the cell, normal cell, which is appear in the histopathology, or the tissue type of origin. So the precise incidence in the epidemiology, the precise incidence of different bone cells, bone tumors, is not known because many benign tumors are not biopsies. So the benign tumor outnumber malignant tumor by at least several hundred-fold. So benign tumor have their greatest frequency within the first 3 decades of life, whereas malignant tumor are more common in elderly. So the malignant tumor is more common in elderly, while the benign tumor is most commonly in younger age group. And due to the presence of different bone tumor, and because the benign tumor are not always discovered early and taken a biopsy to know this, so there is an increase in the number of benign tumor other than the malignant tumor. In a clinical evaluation of the bone tumor, bone tumor, firstly, according to the age, as I said, many benign tumor occurring and presenting during childhood and adolescence, although the malignant could be occurring like Ewing sarcoma and osteosarcoma in childhood. Chondrosarcoma and fibrosarcoma occur more commonly in elderly in age over 70 years of old. Metastatic is more common than all the primary tumor. So according to the age, and the metastatic tumor are the most common tumor than all the primary tumor. The sex. Many tumor are clearly predominates in at male, although giant cell tumor and fibrous dysplasia are more common in female. Site of bone tumor. Most of tumors are found in the metaphysis of long bone. As we know that the bone is different site, which is the diaphysis, metaphysis, and epiphysis. So the most common site for bone tumor is the metaphysis, but Ewing sarcoma occur mostly diaphysial. Size of the lesion. Large tumor are more likely to be a malignant than a benign tumor. These in clinical evaluation can give us a clue about the type of the tumor. Numbers of lesion, multiple lesion at a young age group mostly benign, while in older age group mostly are malignant. Now, the clinical symptom and sign of tumor are different. Most commonly, the tumor is, especially the benign tumor, is asymptomatic. So, the common presentation of bone tumor, especially benign, is asymptomatic and frequently found or diagnosed incidentally, where we do X-ray for other, like trauma or anything, for other lesion or any other pathology. We found incidentally that there is a bone tumor. So the more common benign tumor lesion frequently present as asymptomatic. Pain, the most common complaint of pain indicate the nature of the lesion. And the pain that occur in bone tumor either due to rapid expansion of the tumor, stretching of the surrounding tissue, central hemorrhage inside the tumor. There will central hemorrhage cause pain. Central degeneration also may cause pain, or may present with pain due to pathological fracture, or may do pain due to erosion of the nearby nerve or nervi structure. So these are the causes of pain in tumor. So the pain could be due to rapid expansion, stretching normal tissue, invasion of the surrounding tissue, central hemorrhage, degeneration in the tumor, and insidious incipient pathological fracture. Due to fracture, there will be pain. Other presentation of the tumor, like a mass. So a patient feel a mass in near the joint, or in the bone, or in the leg, anywhere. This mass appear as a hard lump, and so the patient will seek a medical advice. Other presentation of bone tumor is neurological symptom, like paresthesia and numbness, especially where there is a pressure or erosion of the nerve component. Other, as I said, in the pain presentation, the pathological fracture. Bone tumor may appear as a pathological fracture, and due to trivial trauma or due to minor trauma, there will be fracture. And when we do X-ray, we see that there is a bone pathology which lead to pathological fracture. So trivial trauma, minor trauma will lead to fracture of the bone because the bone itself is disease. Joint stiffness due to limitation of movement of the joint due to pain, and muscle wasting. Other may be any clinical and sign and symptom of the pain of the tumor, back pain, especially the spinal tumor, will cause stiffness and painful scoliosis. There are the laboratory evaluation of the bone tumor. Any bone tumor, we send laboratory as a routine test for blood test, but these will have anemia, raised ESR, raised alkaline phosphatase, but all these are not specific, or we cannot, according to these laboratory tests, we cannot differentiate between malignant and a benign tumor. Also, we can send, in case of hematopoietic origin of the tumor, we can send serum electrophoresis, maybe reveal abnormal globulin fraction, or we can send also Benz-Johnson protein in case of multiple myeloma, Benz-Johnson protein in urine, which is due to multiple myeloma. The other tool for the diagnosis or to differentiate malignant and benign tumor, or what we send for any tumor, we send a radiological evaluation. The most important thing in radiological evaluation is the X-ray. X-ray is a best test for diagnosis. The X-ray feature, according to the nature of the tumor, will have a special characteristic or radiological finding. So in benign tumor, we will see that the tumor is well circumscribed, well-defined age. This is circumscribed and well-defined age. Also, we can see a narrow transition zone of between the normal and abnormal tissue. So we can, from here, we can see the normal and abnormal tissue. No periosteal reaction. Periosteal reaction, this is the periosteum which is adherent to the cortex, and there is no elevation of the periosteum and no periosteal reaction. We can see a sclerotic area, a sclerotic border, which indicates that this is a normal bone reaction. So this is a benign tumor, the X-ray sign of benign tumor. We have also what we call it is a benign tumor, but it is aggressive tumor, which is there is a new corticalization. So this is double cortex. Expansion. This is, as this giant cell tumor, we see there is expansion. Aneurysmal bone cyst also, we have expansion. So the tumor is outside the normal boundary of the bone. Thinning of the cortex. This is the cortex. This is the normal cortex. We see here there is thinning of the cortex, which will lead to fracture. Usually either lytic plus reaction or narrow zone of transition. Also there is a narrow zone of transition. Now the X-ray sign of malignant tumor. What we give as a clue for that this tumor is mostly malignant from X-ray, which is there is more reaction. We see here more reaction in the bone. Large, the bone or tumor is large. Permeative, so it is outside the bone. This is outside coming the bone. Codman triangle. This is the Codman triangle here, which is maybe not so clear. This is elevation of the periosteum with subperiosteal bone growth, which will lead to what we call it Codman triangle. So elevation here of the cortex. There is lay down of because the periosteum will be activated, so will be lay down of new bone formation. This will cause like what we call it triangle, which is called Codman triangle, which is a pathognomonic or used for diagnosis of malignant behavior of the tumor. sunburst appearance يعني مثل ما نقول احنا شعاع شمس طالع، يعني هنا مو كلش واضحه، بس هي نشوف انه البرميشن اللي موجود ان البون سيلز طالعه خارج البون كورتكس which give rise appearance of sunburst. mouth eaten like the erosion due to erosion of the cortex or erosion of the soft tissue. In case of metastasis, we see more than one lesion in the bone. Other mode of radiological evaluation, which is the bone scintigraphy, we used a radioactive substance like technetium-99. This isotope scan used for staging and skip lesion and assess the response to chemotherapy. CT scan also can be used, in which we demonstrate cortical and endosteal destruction. Also assess the extension of the tumor and its relation to the adjacent viscera. MRI, which is also used, will give us anatomical detail of the tumor and the soft tissue for staging and for the follow-up of the tumor. So in case of bone tumor, we have do conventional X-ray. Is it benign? We have, and this is the algorithm for the management, for the diagnostic tool. If it is benign, appropriate treatment. If it is not clear diagnostic problem, poor refrigerate, so we will do CT. After CT, if it is benign, go to benign. If it is probably malignant, we go to staging examination and MRI. So in conventional X-ray, we have three-way. Either it is clear benign, so we go with benign, either which is probably malignant, so we'll go further investigation, which is staging, and do MRI. Or if there is a diagnostic problem and we cannot know what's this type of tumor is benign or malignant, we can do the CT scan. After CT scan, if it is benign, go to the benign. If it is malignant, go to malignant. If it is still not clear, go to the biopsy. And the biopsy is the best and the accurate way of diagnosis. The best thing to diagnose the tumor is to see the tumor cell. The best is to see the tumor cell. So the characteristic of tumor will appear if it is there is bone sclerosis, calcification. This means that it's osteoid. Popcorn or arc ring calcification, bright on T2 and low on T1. It is a chondroid. This is characteristic in case of MRI. Lytic lesion, low on T2 and low on T1. This is fibrous tissue. Lytic will circumscribe bright on T1 and dark in T2 and dark in T1. So this is a cystic fluid. These are the characteristics for bone tumor in MRI. Now the site of a tumor also will give us a clue, which is the epiphyseal. We have Ewing sarcoma, osteoid osteoma, metabolic bone disorder also may be seen in case of confused as a tumor in case of loser zone, adenoadenoma, fibrous dysplasia. Epiphyseal, maybe epiphyseal site. We have chondroblastoma, clear cell chondrosarcoma, giant cell tumor, or ganglion of the bone. Age of the tumor, age of the in case of osteogenic sarcoma and Ewing sarcoma, it is about 20. 40, it is giant cell tumor, chondrosarcoma, and lymphoma and metastasis. In case of 60 years, there will be more chance for metastasis, myeloma and chondrosarcoma and fibrosarcoma. Importance of radiology is to know what's the importance of the radiology. The importance of radiology is to know the exact location of the lesion, the extent of the growth and metastasis, and also we can see the aggressiveness of the lesion. The other mode of diagnosis of the bone tumor, and as I said, which is the most important, it's what we call the bone biopsy. So the best thing to diagnose tumor is to see the tumor cell. It is essential and accurate diagnosis and the planning for treatment. In case of biopsy, we have two types of biopsy, which is closed biopsy and open biopsy. The closed biopsy عادة يكون large bore or large bore, small fine needle, aspirate through aspiration, so we don't have to open the soft tissue. Advantage, we can use it under local anesthesia, and we can use it outpatient, small wound, this complication, and it is suitable for spinal tumor with under CT guide can be used. So we have closed biopsy, which is wide bore needle or small fine needle. We do aspirate. Disadvantage, it is not always yield sufficient material, so false tissue. So the most important of disadvantage, because will give a small amount, or we cannot even reach the exact pathology. This is the disadvantage of the closed biopsy. The other mode of biopsy is open biopsy. Open biopsy, we have two types of open biopsy, which is incisional and excisional. الفرق بيناتهم الانسيجنال we open the tumor and take a piece of the pathology. Excisional we excise all the tumor and send for histopathology. This is the difference between excisional and incisional biopsy. Advantage of open biopsy. Advantage of open biopsy is we can get a reliable amount of diagnosis, even muscle, skeletal, everything we can take accurate for diagnosis. A disadvantage, it is lead to large wound, risk of hemorrhage, pathological fracture, contamination, infection. This is as a complication of even as a surgery. So in general, open biopsy is preferable than closed, except in inaccessible sites. This is the message. The open biopsy is preferable than a closed biopsy, except in case of inaccessible part. So it's better to get a good piece of the tumor, or even if you can't remove all the tumor, so it's better to use open biopsy. Principle of open biopsy: get some idea about the anatomical and pathological pattern of the tumor under GA without tourniquet in order to avoid seeding of malignant cell. Get short way to reach the pathology. Avoid opening of muscle planning, and avoid opening vascular fascia to avoid spread of the malignant cell. أيضا take piece of normal and abnormal tissue like the pseudocapsule. Take from the peripheral site other than central site, because in case of central we may have central necrosis, so will give a false result. The skin incision we have to use at longitudinal other than transverse, and should be in the line of next or definitive treatment for the second operation to remove all the scar with the new surgery. Also make sample from soft tissue rather than bone tissue if tumor is penetrate the bone. So أيضا incisional biopsy for most aggressive tumor and staging malignant, while incisional biopsy for small benign tumor. So excisional biopsy because the tumor is small, so we can excise it all. Incisional biopsy if the tumor is large. Now we come with the staging of the tumor. Staging of tumor: in case of benign tumor we have grade 1, which is asymptomatic and diagnosed by chance or accidentally. G2 اللي هو causes of bone, or there is a mass, so there is a symptom. grade 3 أو stage 3 اللي هو pathological fracture or expansion of the soft tissue. This is the staging of benign bone tumor. While the malignant bone tumor, it is classified as G1, which is aggressive tumor with risk of spread in 25% as secondary chondrosarcoma. Grade 2, which is a very aggressive tumor and spread in more than 25, like fibrosarcoma. In case of G3, which is a metastatic tumor. In case of the bone musculoskeletal tumor classification or staging of the bone, which classified as stage 1A, it is a low grade intracompartmental. This is low grade. This is the compartment of the soft tissue. So like in the thigh we have two anterior and posterior compartment. So if it is only in the anterior compartment and it is low grade intracompartmental. Grade stage 2, stage 1B, which is low grade but extra compartmental. It is outside the compartment. Stage 2A, which is high grade, the high grade tumor but it's intracompartmental. Stage 2B, high grade but it is extra compartmental. and stage 3 اللي هو any grade سواء كان A or B but with distant metastasis. This is the Inking classification of musculoskeletal tumor or musculoskeletal tumor society staging. So grading of the tumor depend as this we said, low grade and high grade. What is according to what? We consider that the tumor is high grade and low grade according to the cell polymorphism, tumor differentiation, necrosis, and mitotic activity. According to these, if they are high, this is a high grade tumor. If they are low, they are low grade tumor. Differential diagnosis of tumor, it is like soft tissue hemangioma, myocyte ossificans, stress fracture, and bone infection. These are the differential diagnoses or the lesion that may be mistaken as a bone tumor. Treatment of tumor, the principle, I will discuss principle of the treatment. We have firstly excision. This is mostly for a benign tumor. Excision. We have in the excision 4 types of excision: intracapsular excision or curettage. So we open the tumor and remove the tumor from within the capsule, from within the tumor, or by curettage curate the tumor. And we can add any like bone replacement or artificial bone, or if we don't have, we can use a bone graft. So it is excision. We have 4 types. First is intracapsular excision or curettage. This is other type of curettage. We see this is the curate and remove the bone. We do by burr. We remove all the sclerotic eggs. And we can use bone graft or bone supplement. This is also benign tumor. We put a bone graft or bone cement, and we do also fixation. This is the intracapsular curettage or intracapsular excision. The other is marginal excision. Marginal excision of the bone. Marginal excision, this goes beyond the tumor margin. So we not remove the tumor from within. We are gates free normal tissue with the tumor. This is a marginal. So dissection of malignant tumor is carried through the reactive zone. There is risk of recurrence up to 50%, and the result cavity can be filled with bone graft. So in case of tumor, the marginal excision, we remove the tumor with a safe area, with a normal safe area. This is marginal excision. Other type is it is wide excision. The section is carried out through the normal tissue. This is appropriate for low grade intracompartmental lesion with risk of recurrence of below 10%. This is wide excision. So in this picture we see this is the intralesional or intracapsular excision. This is the marginal excision. This is the wide excision. This is the 3 type of excision. The fourth type is radical excision. Radical excision, which is remove part of the bone and we use prosthesis. This is the radical excision. So this is the excision of the margin: wide excision, wide local excision, radical excision. These are the 4 different type of excision for the treatment of tumor, especially benign tumor. Other mode of treatment: the best treatment of any tumor is to get rid of the tumor with the normal part of the normal tissue. And the best thing is, in case of like malignant tumor, it is the amputation. If there is a considerable difficulty of limb-sparing surgery, particularly for a high-grade tumor, or if there is doubt whether it is intracompartmental or extracompartmental. So we have to do amputation, which is preferred. However, nowadays this approach is uncommon in a specialized unit because they try to use the limb sparing surgery. So we can remove part of the limb and replace it by prosthesis. Chemotherapy, other mode of treatment like any other tumor, and this is now also the preferred method because of development in the pharmaceutical treatment for the tumor and especially the biological substances. So it is more promising. Other is radiotherapy in case of high energy radiation. This will lead to destroy by radiosensitive tumor can be destroyed and used as adjunctive therapy for operation. And it is indicated for highly malignant tumor like sarcoma and can be combined with other modality like chemotherapy and in case of inaccessible lesion. Now we reach the end of the our lecture today. Thank you very much.